All right. Good morning, everybody. Happy Friday. Welcome to this week's AMSSM Sports Ultrasound case series. This week we've got Bill Berrigan. He's PMR trained at NRH National Rehab Hospital out in DC. He's the current primary care sports medicine fellow at Emory down in Atlanta, and he's staying on staff, or staying at Emory, I should say, next year for an additional year, doing a chief fellow year with his research focus on chronic exertional compartment syndrome. And today he will be talking about a rather interesting case, a case of a subcoracoid cyst resulting in a brachial plexopathy. So with that, I will pass it over to Bill and we will get going.
All right. Good morning, everyone. Can you all see my screen?
Looks good.
Perfect. So thanks for having me on today. So I'll be going over our standard shoulder protocol with a slight deviation based on our case presentation for this patient. I have nothing to disclose today. Before we get started, I wanted to thank a couple people. So Dr. Robbie Bowers and Dr. Sarah Reiser, who were directly involved within this case, and also for their assistance in my education this past year, and Dr. Ken Mauner for his mentorship, in addition to really helping me refine my skills over the past year. And really everyone at Emory has just been incredible. So our objectives for today is to really go over that sonographic protocol for the shoulder, and then we'll apply it to this case. And as we go through, I'll review the relevant anatomy, and we'll kind of break it down by sections to eventually come up with this full ultrasound report. So our case is a 49-year-old right-hand dominant female. She presented to us with left shoulder pain. And it had been ongoing for about 2 weeks, and no trauma and no specific inciting event. It was really vague pain, as she described, in the left chest, so the posterior shoulder, also in the axilla and the lateral ribs. And then she even said it would go underneath the breast as well. And then occasionally she would have these intermittent symptoms that would radiate into the hand, specifically the thumb and the index finger. These symptoms were exacerbated by overhead movements, when she outstretched that arm, and when she laid on her side. She didn't have any recent viral illness, no infections, no cardiac history, no real pleuritic symptoms, and no recent rashes that she was aware of. So when we took a look at her shoulder, so her shoulders were rolled forward, her scapula was a bit protracted. She had some tenderness of palpation in the posterior shoulder and the rhomboids, and also within that upper trap, but she was pretty tender over that pec minor. Her range of motion overall was normal, and special tests were non-contributory in this case. But when we compressed the pec minor, it reproduced her left arm pain. And then when we outstretched her and hyperabducted the arm, it reproduced her symptoms. So then we took a look at her posteriorly to assess the scapula, and we saw that there was an aspect of dyskinesis on the left when we compared it to the right. Her cervical spine exam was relatively normal. She had some tenderness over the paraspinals, and her end range lateral rotation to the left provided some discomfort, but didn't reproduce all of her symptoms. Her strength was normal, sensation was intact, and the reflexes were symmetrical, no upper motor neuron signs, and she had a negative Sperling's as well. So we had obtained plain films prior to her coming in, and didn't contribute to her case specifically. There was no acute injury, no fracture, no dislocation, no significant degenerative changes that would explain her presentation. So at this point, our differential was very broad. I mean, we thought about Parsonage-Turner given its acute onset. She didn't have any recent viral illness or infection, and she wasn't weak at this point. What about brachial plexitis or neurogenic TOS, possibly entrapment neuropathy? But then common things being common, about cervical radic, wanted to look at the cuff to look for impingement or tearing. And then, I mean, we thought about some other aspects as well, but the ultrasound was going to guide where we were going further. So this is our standard evaluation of the shoulder protocol. So I used a 15.6 megahertz transducer linear. I've used the Sonocyte export machine. I like to do the protocol with the patient seated, and you could do it supine or in the lateral decubitus for different positioning, but I tend to do the full examination in the seated position. So I start in the anterior portion, looking at the biceps tendon, and then change into a different image looking at the subscap. And then I'll move superior and lateral to look at the AC joint and then the subacromial. Then I'll look at the rotator cuff, and then I'll finish up with the posterior exam. And again, given this patient specific presentation, I'm going to look at the Pec Minor and possibly a TOS evaluation as well. So this is our home base for the shoulder. We're starting at the bicep tendon. We're in short axis, transverse image. Bicep tendon is sitting right in between the greater tuberosity and lesser tuberosity. I'm going to follow it all the way superior to where it gets into the rotator interval, and it just takes on a little bit more of an oval shape. And then you follow it distally until you can get to the level of the pec tendon. And you're looking for any focal tearing, any signs of tendinopathy, thickening of the tendon, or fluid around that tendon that would be suggestive of tenosynovitis. Know that there's normally a little bit of fluid around the bicep tendon, so you don't want to miscall that. And then you could do external rotation to assess for any subluxation of the tendon as well, external internal rotation. That might be suggestive of like a subscap tear or one of the ligamentous tears, all of this which were not present within this patient. So we still have the patient's hand kind of supinated on their sitting on their leg or their thigh. And now we can go into long axis image, and you could assess for sonal palpation to see if that reproduces their symptoms. You can turn on Doppler as well, looking for hyperemia. Again, this was normal within this patient. So then I'll bring the patient into external rotation to look at the subscapularis tendon, and you want to evaluate it in its full extent. So the superior portion of the fibers all the way down to the inferior portion of the fibers, and most tears will occur at that superior portion. And you're looking for any tearing or any signs of tendinopathy within the area. And then you can do a dynamic assessment as well. And for this, you're looking more for any signs of impingement, so bunching up of the fibers, any fluid within that subcoracoid bursa as well, which was not present. And you go into short axis to take a look at the subscap in this area. And what you can see is that the subscap has these musculotendinous slips. So there's little focal areas of hypoechotonicity. You don't want to miscall this for a tear. These are just the musculotendinous normal slips of the subscap tendon. So overall, at this portion, our bicep tendon muscle was normal in appearance. It was sitting within the groove. There was no tears, no tendinopathy, no tenosynovitis. Our subscap tendon was intact. There was no tendinosis or tearing, no fluid within that subcoracoid bursa, and there was no sonographic evidence of impingement with dynamic imaging. So then I'll move superior to look at the AC joint, and you could assess for degenerative changes, distal clavicle osteolysis. You could also look for fluid within the joint. If there's a large amount of fluid, it would be significant of a geyser sign. You want to be looking for the rotator cuff tear. And then you can also assess an acute injury for any sort of gapping by having the patient place their arm on the opposite shoulder, all of which were not present for our patient. So then I'll slide laterally to take a look at that, the supraspinatus gliding underneath the acromion to get a dynamic view looking for impingement. We're looking to make sure that the supraspinatus is gliding nicely within that area. And there's no bunching of the fibers or abnormal movement there, and there was no evidence of impingement. So our AC joint was normal. There was no degenerative changes, fusion or synovitis. Subacromial bursa was normal, no evidence of bursal thickening, distension, or subacromial fluid. So then I'll bring the patient into their next position, which is that modified CRAS, and I'll have the patient put their hand within their pocket, or basically putting their palm on that posterior aspect of the iliac wing to really bring that supraspinatus into view to get this nice bird's beak-like appearance. And the supraspinatus, the articular side of fibers, kind of takes this curved appearance, whereas the more bursal side is more flattened in an aspect. Again, you're looking for signs of tearing, some of tendinopathy. You can look at fluid within the bursa within this area as well. And then I'll go into short axis or the supraspinatus, and it's important to evaluate the most anterior aspect of the supraspinatus. You know you're doing this by getting the bicep tendon within view, and then you're looking for tearing. You could also look for any cortical irregularity that might be an indirect sign of a tear, or cartilage interface sign as well, which were not present for the supraspinatus. And I'll slide posteriorly to get that infraspinatus within that short axis view, and just bringing the full extent of the tendon in. And you can slide more laterally to make sure you're on that middle facet for the infraspinatus to take a look at that. I'm looking for a tearing of the tendon. So you can also take a look at the infraspinatus within that modified cross position, sliding posteriorly from where you were at the supraspinatus, kind of looking for the change in the facet. But I also like to look at the infraspinatus tendon by starting at the spine of the scapula and moving inferiorly and then laterally and at this point, the patient's arm is across their body and with their palm located on the opposite shoulder to really bring that into view, assessing for any signs of pathology. And then I'll move inferiorly from that infraspinatus to look at the Teres Minor tendon. And the Teres Minor is a great reference tendon because it's rarely torn. So if you're looking for a tear for the infraspinatus, you can compare it to the Teres Minor to get a good reference. You can take a look at the muscle, and this is kind of transitioning to that posterior examination. And so I'll slide downward from the spine of the scapula. Let's look at the infraspinatus, which is usually twice the size of the Teres Minor. It's separated by this little ridge within the scapula. So that's kind of how you're able to see the difference between the infraspinatus and the Teres Minor. And then you could follow the muscle out as well to the tendon to make sure you're at the correct portion of the tendon. Within the muscle, you're looking for signs of hyperechogenicity, any atrophy or of the muscle, and you can compare them as well to side by side. You can also do an extended field of view to look at the supraspinatus if it's clinically indicated, which we didn't do. So overall, our supraspinatus is intact, no tendinosis or tearing, no sonographic evidence of impingement with dynamic imaging. Infraspinatus is intact, no tendinosis or tearing, normal muscle appearance without atrophy or fatty infiltration. And this is the same for that Teres Minor tendon and muscle. So finally, I'll finish up with the posterior aspect of the exam, looking at that glenohumeral joint. So you get the glenoid and the humerus within view. And you could see that nice, strong central tendon of the infraspinatus lying over the glenohumeral joint. And within there also you see a hyperechoic triangular structure that's denoted by the asterisk here, and that's your labrum. You can assess for any hypoechoic clefts in the area that are significant for a tear or any signs of tearing. You also look for a paralabral cyst within the joint itself, looking for a fusion or any synovitis there. You can do a dynamic examination looking to try to bring out if there's any fluid within the joint by doing internal rotation and external rotation as well. And there was no signs of pathology here. So then I'll move the transducer slightly medial, and I'll rotate the medial aspect to really bring in that spinoglenoid notch. Here you're looking for a cystic structure. There's a normal venous structure within this area, so you don't want to miscall that venous structure for a cyst. And you could distinguish the two by doing internal and external rotation. And with external rotation, the venous structure will enlarge and then collapse when you go into internal rotation, where that won't occur with a simple cyst. So that's a good way to tease that out. You could also throw on Doppler to aid in your evaluation as well. And then finally, I'll finish up this part of the protocol with the suprascapular notch. So I'll go to the spine of the scapula and move superiorly to assess that notch, looking for any signs of cysts. Again, you can throw on the Doppler within this area, and this is a great view if you're going to do any sort of suprascapular nerve block. Kind of bring it into view by tilting the transducer a little bit cephalad. So glenohumeral joint is normal. There was no evidence of effusion or synovitis. The spinoglenoid and suprascapular notches were normal. There's no cysts or neurovascular abnormalities that were noted. So that completes the kind of the standard shoulder evaluation. But given our patient's presentation, we also wanted to take a look at the plexus, not a full evaluation of the plexus, but to look in specific areas that could be entrapped, like in a neurogenic TOS. So I'll just review the anatomy here real quick. So you have your roots, your C5 through T1 roots, and they come into the trunks, and we're able to see our trunks, and they go in between your anterior scaling here and your middle scaling here. And so you'll see this stoplight looking appearance of C5, 6, and 7 between those muscles. And you have your overlying sternocleidomastoid right here that we'll see on top. So this is what it looks like. So left of the screen is anterior, right of the screen is posterior. So you have this flag-like muscle, the sternocleidomastoid over the top. And then anterior, you could identify your vasculature. But really what you see is that you start to get the plexus coming into view, denoted by the arrows, between that anterior scaling and the middle scaling. And this could be a site of entrapment if there's any sort of scar tissue or possibly an interscaling neurogenic TOS. So there was some papers that have described this. So back in 2013 in the Journal of Hand, Freed and colleagues wrote a technique paper, and there wasn't many patients. And they took images at that supraclavicular fossa, looking at C5, 6, and 7, sitting between that anterior scaling and middle scaling. And they did this at neutral, and then they also did a dynamic motion at 90 degrees, 130, and 150 degrees. And they denoted a positive scan to be indicated by a decrease in that interscaling interval with abduction, and showing a brachial plexus compression. And really, they correlated this with patients' symptoms if they had an onset of any reproduction of their symptoms. And so what they found is that you kind of see a collapse of that stoplight-looking appearance of the trunks when they're in that hyperabduction, and that's what they described as a positive scan. And really what they discussed, so this is a good way to educate patients, is what's happening if you can see this occurring as an adjunct for diagnostics. And then back in 2017, this paper came out describing anatomic variants that could predispose to neurogenic TOS. And so they took 22 volunteer students, so a total of 44 plexi. They had 95 cadavers. They again took those images from that supraclavicular fossa, looking at C5, 6, and 7, those trunks. And what they described as the lack of visible fascia between the anterior scaling and any of the trunks, they described that as a piercing variant. So this is actually pretty predominant within the cadavers. So 63 out of the 95 cadavers had this piercing variant. But then when they looked at the students, they found this in 8 of the 44 students, plexi, and 4 of the 88 had associated provocative symptoms. So what we're looking at here in the top is, so you see your trunks, and you can kind of see that lack of fascia between the anterior scaling and the superior trunk. And that was the most common variant. And then on the bottom, you see basically that anterior scaling is coming in between the superior trunk and the middle trunk. And that was less common, but also described as one of their anatomic variants. So then the other side of compression for the plexus is underneath that Pec Minor, and I'd say this is more common from what we see. And so the Pec Minor comes and inserts onto the coracoid, and underneath that are your cords. So you have your lateral, posterior, and medial cord. And so what this looks like, and this is us doing a diagnostic injection into the Pec Minor for neurogenic TOS, is basically you see your Pec Major and short axis here, and underneath you have your Pec Minor. And then you get your vascular structures. So they're actually artery and vein coming in here. And then adjacent to that, denoted by the arrows, you get your lateral cord of the plexus. So you can see that if you have any sort of tightness or shortening of the Pec Minor, you can get some compression of the plexi within this area. And so this was described by Suture in the Journal of PM&R back in 2012. So they took 15 patients with neurogenic TOS. They compared to 5 subjects without TOS. They took a neutral image with the shoulder adducted, and then repeated this with several degrees of shoulder abduction. usually a 70, 90, and then anywhere between 120 and 150. And what they looked for was a bowing of the pec minor. And they did a specific bowing ratio, and they compared this to the normal subjects, finding that the ratio was higher in the TOS patients than those without. And so how they did this, and this is a normal subject, is so that the top left is at a neutral position, and then it gradually goes to abducted, and C is their abduction at 120. And at the maximal abduction level, they measured that the distance between the posterior edge of the pec minor muscle underneath the apex, and then they measured the apex of bowing, and they divided that apex, which is B within this image, by A, and they got a ratio. And what the percentage they found in the normal subjects was 1.8%. So when we go look at an abnormal subject or one with symptoms, what he found was that you start to get this bowing of the pec minor over the cords. And so when they did the ratio, looking at the edges of the pec minor compared to the apex here, the TOS average was 17.1%. Remember, it was about 1 to 2% within the normal subjects. So circling back towards our patient, we wanted to take a look at the pec minor. And so we got the pec minor and long axis, pec major, and short axis. And what we saw, actually, and denoted by the asterisks here, was this cyst-like structure that was adjacent to the axillary vessels. And we don't, unfortunately, there's not a great view of that lateral cord in this image, but we can see that it's adjacent to where the plexi would be. And so we did a measurement of this cyst, and it was 0.9 centimeters by 1.19 centimeters. And we threw on Doppler, and there was no signs of hyperemia, no real neovessels within the structure itself. And so we attributed this likely to the cause of her symptoms. So the way we describe this is there was an anechoic lobulated cystic mass located medially and deep to the coracoid and pec minor insertion. The mass measured 0.9 centimeters by 1.9 centimeters, and there was no evidence of hyperemia on Doppler examination. This was adjacent to the lateral cord of the brachial plexus, causing a possible mass effect. So I've gone through each aspect of the protocol and how you'd write it within our write-up, but just a couple aspects to add is when you're starting to write it up, you want to have the date, the diagnosis, the referring provider, where it was completed, and what machine you'd use. And then if you had any sort of comparison studies, for which we only have the plain radiographs. And then importantly is to always have a summary at the end. So our findings were that our findings were consistent with the subcoracoid cyst that measured 0.9 centimeters by 1.9 centimeters with a possible mass effects on the adjacent plexus. So we ended up getting an MRI with contrast to make sure it was just more of a simple cyst. And that confirmed the diagnosis. When we aspirated the cyst, we got about 2 cc's of serous fluid. We did send it out to the lab, and it was normal. And so this is a pre on the left and a post on the right, post injection. And she had 3 months of complete alleviation of her symptoms. Unfortunately, the cyst did come back, and so now we're in discussion with our surgeons for removal of the cyst to see how she does. So it'll be interesting to see her outcome within the end. Go Hawks.
Nice. That's a great gift. Well done. Nice job, Bill. That was really well done. The plexus scans are incredibly challenging. You know, most of us, very few of us, I would say, you know, do this on a regular basis. So being able to navigate that area is quite challenging. I thought you did a really good job. I just have one question and a couple points to make quickly. Did your ultrasound or MRI, did it show where the cyst was originating from?
No,
it's the coracoid, but where did it come from?
Yeah, that's an interesting question, because that's what we're kind of trying to figure out at this point, because within the ultrasound examination, we couldn't find it like originating from the joint anywhere. I mean, we didn't see the stalk of the cyst, and the MRI, the brachial plexus, didn't really reveal that as well. So in talking with our surgical partners, Dr. Wagner, he wants to get an MR arthrogram of the shoulder to see if we could see where it's originating from. I mean, the only real case studies that I saw out there was, I mean, cysts from like a subscap tear that was causing cysts adjacent to like the lesser tuberosity, but not in the region that we were looking at. And her subscap was normal. So that's the ultimate question that we're going to try to answer before he goes in there and removes it.
Sure. Yeah. It's just interesting. And, you know, I would certainly do the exact same thing, you know, especially in that area, getting the MR with contrast to make sure you're not, you know, plunking the needle into something that you probably shouldn't. So a couple quick points. You know, I appreciated your you walking us through your shoulder protocol. You know, I think a lot of us do this very differently, and there's no wrong way to do it. I tend to have all my patients supine. I've got a very strict regimented protocol and sequence of structures that I go through, which is a bit different than what you went through. And I think all of us do it very differently, and there's no wrong way to do it. So I always appreciate, you know, hearing how other folks kind of walk through their shoulder scan. And then with plexus scanning, again, I don't do a ton of this, to be completely honest, but when I do, you know, I think there's probably two main ways to navigate yourself through the plexus. You know, we talk about the sagittal oblique technique, which is what you described, you know, where you look for the anterior middle scalenes and look for those roots, specifically 5 through 7, coming out through that interface. But there's also a technique, if you're transducers, and an anatomic axial technique, where, you know, essentially starting at the anterior neck level of the thyroid, scanning lateral or posterior, and you'll see a very characteristic, or the transverse process of C7 lacks this anterior tubercle, which is very characteristic of that location. And I think that's a good spot to get oriented and know where you're at, to, you know, help further your scan. But either way, when I scan these, I do exactly what you did, you know, starting with the anterior middle scalene and going from there. So that's all I have. Doug, do you have anything you want to add?
Yeah, nice presentation and a good review of the protocol. Like Ryan said, I think, you know, shoulders are probably the one area where everybody's comfortable with the protocol, and there's differences, and just a couple things I do that are different. And, you know, when I see an older population, I do a video of the supraspinatus from the interval, so anteriorly all the way posteriorly in its long axis. And then I do a video proximal to distal in the short axis. And the reason why I do this is I can go back when I read these and reconstruct a rotator cuff tear. And by going through this video carefully, I'm always glad that I just didn't have still images. So that's become part of our protocol. I don't actually include impingement, dynamic impingement in the protocol unless it's a younger athlete, or specifically there was a reason in the older patient. But when I do impingement, I tend to do it in two different areas. One is where you showed over the acromion, and then two is I go anteriorly over the coracoacromial ligament, both long and short axis. And oftentimes you'll see impingement on the ligament rather than the acromion itself. And then just another trick that I use with the infraspinatus is I actually externally rotate the shoulder joint and then adduct, and that will open up the infraspinatus both in long and short axis. Something to think about. Ryan, I know you lay down the patient, but you say there are a few differences in your protocol. And since this is the focus of this case series, what are some of the other differences that you have?
Yeah, so, you know, when I run through my structures, the main difference is that they're supine for the first half and then lateral decubitus for the second. And, you know, I'll similarly to what Bill said, I'll start with with biceps, short and long, then subscap, then AC joints. And that's where I end my basic structures for my anterior shoulder exam. And then I have them roll over lateral decubitus. Next structure for me is posterior glenohumeral joint. While I'm there, I then do my evaluation of infra and teres. Following that, I'll do my notch evaluation, so spinoglenoid followed by suprascapular, and then the last thing that I do is my supraspinatus evaluation. So I'll still have them the side lying into that kind of modified crass, which I found that it, at least in my opinion, tends to be a bit more comfortable for folks. They can let their elbow kind of hang back and gravity pull their elbow down to get them into that position. So that's the biggest difference for me. Like I said, supraspinatus is the last thing that I'll do, and
Yeah, so I mean, it's always interesting to hear how other people do things. You know, just talking about that coracoid area, oftentimes, you know, when we start out with the long head of the biceps and then go to the subscap, we will see fluid anterior to the subscap, and that's the subscap bursa. And that subscap bursa communicates with the subacromial subdeltoid bursa. It's been reported anywhere probably from 15% to 80%. And that's always a clue that there's fluid in the subacromial bursa. And then my last comment is back to the plexus. For me, the most common reason to have a similar type of picture than what you presented was actually hardware from an ORIF of a clavicle fracture. So I've seen several of these where they cause in a sense, a friction kind of fibrous mass that then impinges on the brachial plexus in the subclavicular region. And then I do the same thing, Ryan, as you do when I do a plexus evaluation. I start with the roots as they exit the foramen and make sure I count them down. And I tend to look very carefully in the interscalene region because there's lots of variation in the interscalene region, lots of accessory ligament structures that these roots will, in a sense, wind around. And no one really knows the significance of that, but you'll see that quite commonly. And then I continue my short axis all the way down. And then I go to long axis, particularly on the cords as I go under the clavicle and into the sub-pec minor and do dynamics evaluations in the long axis to see if they slide well. I've seen things like hypertrophic changes of the subclavius muscle impinge on this, for example. So I go both long and short axis, particularly in the sub-pec minor region and the subclavicular region. So nice presentation. That's all I have.
Great, thanks. Thanks as always, Doug. Those points were always helpful for all of us. All right, great job, Bill. Like I said, this is a very challenging area that most of us aren't doing on a regular basis. So really well done. Two points, maybe 3 points. 2 points of housekeeping here. So as with always, off next week. I know fellowship is ending for these guys in less than a week. However, we do have 2 current fellows that have been gracious enough to present to start during their lives as non-fellows. We will have another fellow, Katie Bartolo, on July 9th. She'll be presenting a case, and then one other fellow, Allie Warwick, will be presenting after her. After that, beginning in August, we're going to transition back into our core faculty presentations, and we'll continue that for the fall and the first part of the winter. So with that, everybody have a great Friday, happy weekend, and we'll see you all in a couple weeks.